Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice. Hello, this is James, and welcome to episode 38 of the Mad in America podcast. This week, Emily Shearer Cutler interviews clinical social worker and activist Jeffrey Michael Friedman.
So joining us this week is Jeffrey Michael Friedman, a licensed clinical social worker and an activist in the psychiatric survivors movement. Jeffrey provides trauma-informed therapy to victims of various forms of abuse and violence, including those who have survived abuses within the mental health system. He is currently completing his PhD in family therapy, where he's conducting research on recovery from adverse childhood experiences. In addition to his work in the mental health field, Jeffrey is actively involved in the harm reduction movement, which supports human rights and non-coercive services for people who actively use drugs. Jeffrey, thanks so much for joining us today.
Thanks for having me, Emily.
Can you tell us a bit more about how you became interested in the topic of forced psychiatric treatment?
Yeah, the starting place that I generally start from in terms of what led me to this is my own experience in middle school at Welsh Valley Middle School. It was in sixth grade after leaving elementary school, and at the time I was about 6 feet tall when I was in sixth grade, and I think particularly it was at a time when I was growing up, and my hormones were kicking in, and I was somewhat shy and introverted, and I just wanted to fit in really and look like everybody else. But being that I was that tall, I really couldn't. And one of the ways that I had a hard time really just being outgoing with my peers, but I decided to take on this persona of a sort of class clown, and eventually, sort of the authorities of the school start sort of tracking you and whatnot. But then after the sixth grade year, they basically told my parents that if I wanted to stay in the public school, they basically gave me this option that I could go into this special program at a different middle school that was about a 20-minute drive in the same school district that I was living in. They'd provide these really great services, and it'd be all paid for. I remember my parents telling me that news in the summer, and I was really distraught by it, and particularly because I had friends at this school, and I was going to a school where I knew nobody. And when I got into the program, I remember that they also identified me as a bad kid, and they sort of used this sort of, it wasn't really necessarily I wasn't using drugs, but they sort of applied this kind of gateway theory of behavior that I was doing this, and then this is going to lead to, violent crime and really heinous violence. But it never led to that. But so they had a little bit of that model of what I was doing then. Anyway, but when I was in the program, it was called Project Now, which was a very weird name. It was an acronym that stood for New Options Work. And several of the other kids in the program were much more violent, and they were doing some more criminal activity and were using illicit drugs at the time. I mean, initially I liked them because they were they seemed more cool. They were engaging in more sexual activities, and they were a little bit older than me, and they just seemed more cool. But I sort of became friends with some of them, but because I sort of still do have sort of a protective Jewish mother. She sort of scared me that I don't want to get too involved with these kind of guys, and I never really socialized with them outside of the school because they were engaging in more risky activities. And I think I felt that I was in enough, this shift and taking me out of the mainstream in the special school sort of internalized some of the sense of being different and being ostracized is what I was looking for. And I didn't want to further I became a little bit more fearful of engaging in other things that could put me further away from the mainstream. Yeah, so this is sort of a fundamental experience that I feel that stuck with me, and it's what led me into this identifying with psychiatric survivors and also the harm reduction.
Yeah, what do you think is the parallel between that experience and the psychiatric survivors movement?
Well, I mean, the parallel is sort of being identified that you're not fitting in the mainstream, and that you need remedial help to be able to be in the mainstream, taking you out of your sort of the environment you were in to provide more sort of therapeutic support to try to get you mainstream. And in my experience with that, I sort of continued with it till high school, and then they sort of lessened some of the support of it. I felt more mainstream. But I think the key thing to note that in talking with you about this is that kind of this idea to me, in the way I attribute it to Foucault, this idea of self-surveillance, that you sort of internalize some of these ideas of not being mainstream. And I felt that had a little bit of fundamental, my own experience in high school, even though I don't think high school, for many people, even if you don't have this type of thing, is not the most, the greatest experience. But I think it shifted my experience that I tend to, in high school, when I went to the more mainstream, that I isolated more, and I wasn't that social in high school. And I think this experience had an impact on that. I mean, the practical thing, like I was saying before, that it took me away from the initial friends that I made. Yeah, I could have made new friends, but I think this idea of internalizing this experience of difference affected me and inhibited my ability to connect as well in high school.
So a lot of your current clinical and academic work focuses on the topic of trauma. Why do you think forced psychiatric treatment meets the definition of trauma?
Well, just maybe backing up a little bit, I mean, what led me to more of the trauma perspective is trying to find some kind of framework other than the traditional psychiatric nomenclature, taxonomy, DSM, ICD-10, and try to explain people's experiences from more of a trauma perspective. Although the thing I like about the trauma perspective is, to me, it's sort of generative. It's a generative framework, meaning that it can be applied to a lot of different things, and even things like political, cultural trauma, which I like about it. But I also think it's limiting in the sense that it's not always as specific. That trauma is just thrown around all the time. You don't really know what it means, but really, after working in mental health field, I've worked at a state hospital in Pembroke Pines and in the Fort Lauderdale area, and also working at addiction treatment. I sort of saw this theme of traumatic experiences, how it led people to having mental health pathology and problems with substances. So I think it has limits, but I think I like it as a framework for understanding how people suffer. Yeah, but why? Going back to your specific question, why it meets the? I would say what I was thinking regarding this is that there's this term called betrayal trauma, and this psychologist Jennifer Freyd, Freyd, she came up with the term. I mean, she talks about it sort of two basic levels. One is that family members, that people are supposed to be loving to you or close to you and betray you, and how that's traumatic. And the other way is more institutions. So I see a lot of the abuse that happens by the psychiatric system is more of a betrayal trauma. I mean, some people do, some patients or clients or survivors, I guess, they do have the experience of already mistrusting the system to begin with. But certain people, I think, do meet with psychiatrists in the mental health system, hoping they're going to be loving and kind, or at least helpful, and then they're betrayed by them. So I think it is this kind of a betrayal trauma. And going back, I mean, one of the definitions for trauma, like the medical one, is being wound. I mean, another one that I kind of like I got from Peter Levine is it's sort of some experience that leaves sort of a lasting impression on the nervous system, and it sort of lingers long after the event happened. And I think definitely a lot of some of the violence that can be experienced through a psychiatric system can leave lasting imprints on the body. I mean, another thing related to trauma is this sort of idea that we have sort of cultural assumptions of what is traumatic. And we, generally speaking, it's sort of widely accepted that sexual abuse and physical abuse is traumatic. I think one of the key things about trauma is the idea it's not always the event itself. It's how it affects you. The same thing could happen to two people, and it may not be traumatic. They may have the event, and it's the sensation, the experience goes away. But the trauma to me is more that it leaves some kind of lasting memory. Bessel van der Kolk, he talks about sometimes that like people are really traumatized. It's weird because it can be a problem of remembering, but it also can be this problem of forgetting, that they have this memory that they just want to forget. But then also there's a part of trauma that it can only make your memories can be kind of fragmented, that you only remember certain parts of it because, our sort of brain and nervous system has some protective mechanisms that try to keep us safe.
So something we discussed in some of our conversations is that while many people who are not harming anyone else are subject to force, individuals such as Nicholas Cruz, the Parkland school shooter, who have made actual threats to harm others, are free. So why do you think that is?
Right. Yeah, no, this is a complex question, and I'm glad we're having a chance to talk about it together. And for the most part, I really have a lot of hope that people can be de-escalated and a lot of things can be resolved. Even something as dramatic as with Nicholas Cruz's case, they can be dealt with through non-coercive measures. But so that being said, it's just very hard to get people to buy in really from an abolitionist perspective and seeing, that you can actually deal with these problems without using force. But we're not at that place now, and I don't know when we'll be there. But so this is the milieu that we're in. That it is a viable option. It's something people consider. That someone to carry out an act such as he did requires a lot of meticulous planning, and it requires some. I would say it requires some decent level of executive function skills and so forth. And somebody that's in real distress, real acute psychiatric, what's considered like psychotic, I don't think they'd be able to do that. That being said, in his particular case, the other thing is that what also to me that especially the mental health system, they get very rigid and following their rules. And what I've read about some of the reports on him is that when the Department of Children and Family worker came to do this investigation to his home, they found that Nicholas Cruz was being compliant with his medication, and he seemed to be open to psychotherapy, and they seemed to overlook, because he was complying in this domain, they were overlooking, to me, was really the dangerous part of his fascination with violence and weapons, or having the weapons, and also some really pretty extreme racial remarks. And because, like I said, I think people can't, in the mental health field, I think some people get so narrowly focused that they can't see the forest from the trees, that they're just saying, oh, he's following what we want him to do. If he likes guns, so what?
So you think compliance is a big factor?
Yeah, and then the other thing this is a big point that just came to me, is that some of these lines can get kind of blurry. But going back to what I was saying earlier, this might be a little bit controversial, but I think when someone like Nicholas Cruz, it wasn't clear prior to the Parkland shooting, a criminal act that they could convict him for or forcibly restrain him, and I think. In this kind of situation, maybe this could be a positive use of psychiatric force. But from my experience, clinical, primarily, and some research, it just seems like these kinds of people find ways to evade that psychiatric force. And usually the psychiatric force really affects people that are vulnerable, that are into, emotional stress, that are more likely, as a lot of the data points to, are more likely to be victims of violence rather than perpetrators. That's usually the people that become under psychiatric coercion. And going back, I think in this current state, if psychiatric coercion was really helped to confine people like Cruz, that to me could be a legitimate use of it.
I know you've had some experience counseling people who have survived different types of forced treatment, such as involuntary commitment, forced drugging and ECT, and outpatient commitment. What would you say are some of the main psychological effects of involuntary commitment?
Yeah, I think it's they're just mistrustful of professionals, but yet that they do still feel that they're drawn to if they're in distress, to go to professionals. So there's this sort of they feel they need to go to professionals, but they're cautious about really opening up for fearful that could be locked up again or held without against their will, or forced drugs that they don't want to take.
And what about the incarceration itself and the process of being locked up or confined or separated from family members or communities? What do you think the impact of that is?
No, it definitely has a big impact. I mean, I think one of the things that it can do in terms of, especially family, is that it very much reinforces this idea that the person that's being locked up has an internal pathology, and it can be a barrier to the family members seeing their role in the person who's being locked up, their what role they have in the symptoms, and it can be challenging from a clinical treatment perspective, in the sense that as a therapist, that if you're trying to bring up what maybe the family's role in their child or husband, wife, whoever the identified patient is, that they think that they interpret it as like that kind of blaming the parents that has like a history in the mental health field. One time the parents were blamed for like things like schizophrenia, but now like so-called we've moved beyond it, and we know it's like this kind of internal brain disease. And I mean, I think also like if you don't totally buy into that, and sometimes when you question that, then the family members may think that that you're not very smart, or you're not a good, you don't really get it, that they may be mistrustful of you as a therapist because you're not really engaging in that kind of disease model. Very similar with the addiction. I've experienced it too, that if you don't sort of see the internal client, whoever the one who's being sent away, because I think rehab is also like a forced, it can be very coercive, and there can be some pretty ugly practices and the same kind of thing.
So what about the effects of forced drugging and ECT? Do you think drugs and electroshock that are forced onto people affect them differently than when people voluntarily seek out those treatments?
Yeah, I remember David Cohen. I like that he said that there's not consent involved, that it's not medicine, and I think that's a good way of thinking about it, because it's more of a moral kind of punitive criminal justice type almost perspective when there's no consent. It's not, and that's and then I think going back to your earlier question, is I think that's the real thing about it, is if it's not. It's sort of hard if it comes under force, it's hard to then turn it and make it like for health. That's I think the challenge. That once it's forced, it's hard. I mean, I have seen shifts that it can start out as force, and people do maybe develop some insights with it. But I would always say, what is the insight worth the harm caused by the force? Or could you arrive at that insight through other means? And I think if you can, you should always do it through other means.
And what specifically do you think, the harm of the force?
Well, I mean, one is just the categorizing as a trauma, that it could leave lasting memories that are intrusive, and could have like anxiety, like PTSD like symptoms for a while. Like another thing with PTSD, one of the classic symptoms is avoiding, that you tend to isolate because you don't want to get triggered. It could lead to that. It could lead to that kind of, another symptom that I didn't mention earlier is like that emotional numbing, that you just feel numb, and I think it could lead to these kinds of things, and it also could, from like a surveillance standpoint, it could come up on some kind of governmental record if they're doing background checks that you had this done to you. It could affect your ability to purchase firearms, and I think there's a lot of evidence to show that people that are vulnerable, or more, especially that have been diagnosed with mental health problems, are likely to be victims of violence. So think that's a natural to want to be able to defend yourself. One example that I saw recently, which I've come to realize how people love their animals, that they could, like, if they get locked up and they have nobody to take care of their pets. Just also another thing, I think it could just leave people more having a harder time trusting people and institutions that could have negative consequences. Just having emotional distress will not kill you, but if somebody's having a clear medical emergency, if they're a psychiatric survivor, it might make them less trustful of calling 911, engaging with medical professionals. So, when they're really having an imminent physical health issue that could be fatal, that they may avoid it due to past negative experiences with coercive mental health practices.
Absolutely. I've even heard that if someone just has a psychiatric diagnosis or hospitalization on their record, they might, even if they're just seeking regular medical services, they might be locked up or told that it's a psychiatric issue. Do you know, has that happened in your experience?
Yes, no, it definitely can happen. And the other thing I would say about it too is that people with a long-standing psychiatric issues, like in the state hospital environment, a lot of those people do have other medical problems, mm-hmm. and the care that they get for their physical medical problems are not as good as if they didn't have psychiatric diagnoses, and that's one way that I also see it happening.
And then I wanted to say a bit about forced treatment that happens outside of an institutional setting. There's a big push for outpatient commitment. And what would you say are the effects of outpatient commitment or assisted outpatient treatment?
Yeah, one of a lot of people like to think of things from a monetary standpoint, and I guess one of the selling points for the ACE Act, or assertive community treatment, I think that's what it stands for, that it's less resource heavy than a physical institution in terms of money spent, like taxpayer dollars. But I like to think of it from that kind of a Foucault standpoint, that the force is much more overt in an institutional setting, whereas the outpatient version, it can be very it can not transparent, but it can be, the similar type of force, but it's more this kind of, it makes it so that the person internalizes the force in their head, that if they don't take their medication, somebody may show up the door, and it's kind of this, like the Foucault called a modern power, that it makes the client survey themselves more. That's part of one of the effects it has.
So going back to the trauma of forced treatment,
mm-hmm.
How can victims and survivors of forced treatment heal from these different interventions? As a trauma therapist, what would you recommend?
Well, I think it's naturally it happens. Connecting with others that have gone through similar experiences, I think that is very helpful. And a lot of people, I think, do that naturally. But I think one of the dangers that can be with that is that, what makes something traumatic is their own individual experience. And just because one survivor healed in a certain way, it shouldn't be prescriptive that, because this so-and-so did it, that you have to, do it their way. There's many roads. Another thing that's come back that I've learned through my research, this theory that I just I learned about in the past couple of months, called altruism born out of suffering. I think a lot of survivors of psychiatric treatment they can have a horrible experience, but they can be interested in making the world a more benevolent place. And I think there's many ways to do that, but I think, finding some type of cause, that it doesn't have to be forced treatment, but there's so many things wrong in the world that if you can find one that speaks to you and work on that, I think that's a great way to help recover from it.
So healing through altruism, healing through activism.
Right. Yes.
And why do you think the public is so often unwilling to recognize forced psychiatric treatment as a legitimate form of trauma or as something that needs to be healed from in any way?
Well, I mean, I think fundamentally it's a lot of people, as you know, that they have an idea that people that are primarily what falls under the I don't like the term, but it's just, I think some of these words just to make the point is that, seriously mental illness, that like schizoaffective, bipolar, schizophrenia, or psychosis spectrum disorders, that this is people in this type that have these problems, this is what they need. And it's accepted by, psychiatrists that have gone to fancy medical schools and confer wear the white coats and confer a certain level of authority and respect for that they earn those titles.
So, as my final question, I wanted to ask you about your work in the field of harm reduction, which you already talked a little bit about.
Okay.
So how does that connect to your anti-forced treatment work?
And one of the tenets of harm reduction is to really to start where the client is and let them define whatever the goal is that they want, rather than being prescriptive. And there's other forms of harm reduction, but it's strictly about substances. For many people that are really very distressed, that they find that their substances are their coping mechanism. And it's like somebody's really down and out and they don't have much support. The traditional way just to cut them off for their only thing that provides them with any source of hope is to me, highly traumatic. And the other thing is this push for safe consumption sites. Other people use the term safe injections. I like safe consumption because it's more inclusive if people consume their drugs through smoking, inhaling, and so forth. I think that has some parallels with like a respite in the sense that it's places where people can go freely. I mean, I think there is some tracking involved, which can be kind of forced in the surveillance aspect, but they're not. They're basically provided resources. They want a detox, but they're not forced into doing it. I think that has some parallels with sort of the clubhouse kind of thing. But me particularly. Priorly, I had more experience in the mental health field, and I was always questioning the biomedical model. And when I was into the addiction world, they have a very disease model with addiction, and sort of questioning that and looking at the research is sort of what led me to the harm reduction. And a lot of it is also very grassroots, led by people that use drugs, like a lot of like the nothing about us without us. They use that same. It's used interchangeably in both circles.
Yeah, I think in one of our first conversations, you were kind of pointing out the parallel of coercion between the two, that some people are coerced not to use certain drugs and locked up for using certain drugs, and then others are coerced to use certain drugs and locked up for not using those.
Right. Actually, and also, the other link is Saz writes about both topics, and he's obviously a big figure in the forced treatment world. But the other thing I'd want to add with this is, I think something that's a little bit problematic I've seen about both communities is that, every community, they create their little micro groups that I've noticed that it's brought up a little bit in the last Students for Sensible Drug Policy conference. They had a little forum about mental health issues, like people that have mental health issues in the sort of harm reduction, drug policy reform world. They talked a lot about how some of the people in this panel took psychiatric drugs and they found them helpful. And a lot of the other people in the drug policy world sort of shamed people into taking, pharmaceuticals. Like, why don't you just do acid? And and I think it's very clear to be nuanced about it's more the drugs are just drugs and they don't have an inherent value on their own. There's other, the pharmaceutical industry there's power dynamics, and there's power dynamics among the psychedelic community and all these different communities. And I just seen that to the extremes that basically this is a gross extreme exaggeration, but I've seen it. Certain people that are anti-force medications will say, all drugs are bad. They, destroy your brain. And then the other extreme, the drug policy, they'll say, all pharmaceuticals are bad, big pharma, but psychedelics are good, and or if it comes from nature, it's okay. And I think we just need to be much more nuanced and avoid these two extremes.
Yeah, and something that I've liked about your work is that it seems like you focus on letting people make their own decisions.
Yeah, and informed consent. And I think the thing that people mix, it can be very hard to have true informed consent with the very it can be challenging with the pharmaceutical industry and the powers that have, but it still can be done with the proper education. And I do believe in supporting people's lived experience. And if they find a certain medication helpful, who am I to tell them? And that's traumatic to tell them that it's poison, it's big pharma, and if they find something that helps them cope, it's traumatic for me to tell them that they're weak for taking it and they're supporting big pharma and so forth.
And then did you want to talk a little about the parallels between coercive psychiatric treatment and coercive addiction treatment?
I guess the similar link that's different is that one of the things that really funnels the coercive aspect to the addiction treatment is the whole 12-step fellowship, which is a self-help group, which I guess the parallel on the mental health side, I would say, would be NAMI. The AA doesn't take pharmaceutical money, so that's a difference. But I know NAMI takes a lot of funding from pharmaceuticals, but they're similar in the sense that when people are really in more of an acute kind of maybe residential hospital setting, both people from these support groups sort of reach out and try to get the family on board that they have a disease and that they need to go to support groups to recover from the disease, kind of thing. And then another thing I do see, another parallel. You see a lot of people that are so-called in recovery from addiction. They'll go and they'll tell these stories about how that they were broken and damaged, and they'll tell this sort of, it's a very performative, theatrical kind of recovery. So they were addicted, and now they've found recovery, and now they tell the story to other people. And I've seen a parallel in the mental health recovery that they, in certain way, in some individual cases, they could be anti-med, they could be for med, but they'll talk about how that they were very symptomatic and distressed, and then maybe they found peer support or they found NAMI or whatever it is, and now that they're this rock star mental health recovery person. And the more I've seen a lot of talks, probably more so in the addiction world with this, and it's just very performative, the talks. And I think that has a sort of a coercive element to it because it's not really real. They really embellish their brokenness and also their success. And I think that, there's certain people that can do that, but I don't think everybody can get up on stage and do that. And it's a theatrical performance too. But another actually big parallel in terms of the coercive connection is that a lot of people in formal addiction treatment, they'll tell the person, they'll sort of tell them that they have a disease or that kind of disease, psychoeducational, they may be recovered, but they'll always have it. They'll never be like normal. And that's one of the things I experienced in the psychiatric hospital, that the psychiatrist will tell the clients that they have a disease, and it's a brain disease that they'll have for life. And obviously the idea that it being a brain disease in the first place is up for debate, and it's certainly up for debate that many people have shown that it's not for life. But this kind of ideology is often tried to be indoctrinated into the clients in both the mental health and the substance use communities.
And what about physical force? It sounds like there's also physical force used with addiction treatment.
Well, I mean, a lot of it is sometimes a psychiatric treatment. If people, I mean, they use a lot of this terminology, which I think is very ridiculous and funny. Like I mean, it's funny, but it's very damaging. Like this is more of a teenage facility, an addiction one, and a lot of it was not locked, and the clients, some of them just get disgusted and they run away from the place, and then they'll call the cops and they'll use force to get them locked up in a psychiatric commitment temporarily, and then get them back to the place. So that's, and another example that you'll see, I saw also in this place. That kind of, it's more psychological abuse. It comes out of this kind of treatment community approach, TC abbreviation. And when the clients come in they'll sort of indoctrination kind of thing, they'll put them in scrubs to sort of make them feel like a patient. And then once they, behave okay, they'll be in regular clothes, but they act up again, they'll put them in scrubs as a way to sort of shame them. And the other example that I forgot about is often, in terms of physical force, is that this is more so with the wilderness programs with kids, that they'll wake up one of the potential clients at like 3 a.m. and have very intimidating men, like former football player type guys, come in, and if they're not compliant, they'll like tape up their, put tape around their arms together and their mouth and throw them in like a van to go to treatment. So that's more physical.
So do you have any ideas for how the psychiatric survivors community might work with the harm reduction community to challenge public perceptions of forced treatment?
Yeah, I mean, I think just some more dialogues and more, engagement, and having, I noticed recently that they're trying to get people with, I wouldn't necessarily call them more about the people that would identify them as survivors, but I mean, there are certain people in the community that are open to exploring these issues, and just getting more representation, having harm reduction people come to psych survivors events and vice versa, I think would be helpful.
Thank you so much for joining us today. It's really great to hear about all the work you're doing on the issue of forced treatment.
Thank you. Pleasure to be here.
Well, I just want to thank Jeffrey and Emily for that interview, and to say that if you'd like to know more about Jeffrey's work, you can find links in the post that accompanies this interview on madinamerica.com. And we wanted to let you know that Mad in America Continuing Education is launching a new webinar series. Psychiatric Drug Withdrawal Part 2, The Psychiatrist's Perspective on Challenges, Opportunities and Shared Decision-Making. The series of 8 webinars will begin on June 18th and will feature speakers including Robert Whitaker, Dr. Joanna Moncrief, Dr. Sandy Steingard and Dr. David Healy, amongst others. The fee for individuals for this series of 8 webinars is $100, but there is an early bird discount of $50 for those who register by May the 1st. For more information or to register, visit madinamerica.com and use the link at the top right-hand side of the homepage. So, thank you so much for listening, and until next time, take care. Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.